Thanks so much. So the title is provocative, game changer, but what I thought I would do in this section is talk about two interventions specifically where there's clear level 1 evidence proving the benefit. And this is the reason we had these questions in the last discussion session about the number of fetal treatment centers and should it be regionalized. This is the reason there's been expansion in the field. So we talked a little bit about fetal surgery for life-threatening conditions, a lung mass, a teratoma. Fetal surgery has been established for the treatment of complicated twins, and we're going to talk about that using fetoscopic laser photocoagulation. We can also treat something called trap sequence, where one of the twins is quite anomalous, and there's cardiovascular sequela that may require treatment. We've also talked about fetal interventions where we're trying to improve the long-term outcome, exit procedures, for example, and we're going to talk about some innovative fetal treatment also in the third talk, but now we're going to talk about fetal surgery for myelomeningocele in addition to twin-twin transfusion. So again, we have to balance the risks and the benefits, and the great thing is, even with open fetal surgery, the maternal risks are incredibly small. The mom can get an infection. There's obstetric risks, which are there with every pregnancy, and perhaps those are higher in the mom following fetal interventions, but we do select our patients, and so if the mom had significant comorbidities, she's probably not a candidate for fetal therapy, and that has to be carefully balanced. Fetal surgery for myelomeningocele evolved following animal experiments. So one of my good friends, Martin Muley, and his wife did a set of sheep experiments in the laboratory of Michael Harrison in good collaboration with Scott Adzik. And they developed an animal model where they created the myelomeningocele defect in lambs. When that was left untreated, those lambs did have all the manifestations of spina bifida that we see in human babies. And then in a subset of those animals, they began to repair the defect, and they proved that they can rescue the neurologic damage, suggesting that there's a two-hit hypothesis for the neurodevelopmental problems associated with spina bifida. The first is the congenital condition, but the second is there seems to be something, there's a deterioration that happens during the pregnancy, and our maternal fetal medicine experts know this, because sometimes you might see at 20 weeks a fetus moving their legs or moving their ankles even, and then by the time of delivery, that movement seems to stop. So there probably is ongoing harm during the pregnancy from babies with spina bifida, and these animal experiments help to show that as well. Fetal surgery for myelomeningocele began in the late 1990s. Actually, the first case was done at Vanderbilt, done fetoscopically, actually, with not good results. And then the field kind of propagated, and about 300 cases took place in the United States before a study took place. But all the evidence from those cases was positive. These are some pictures early on. You can see the hysterotomy is rather large compared to what we do, but there's the defect, and it's being repaired carefully. The thing that we see that's really cool is that the hindbrain herniation. So one of the manifestations of the Chiari-2 malformation is that the cerebellum herniates down the foramen magnum. And we think that this happens because the CSF is leaking out the open neural tube defect down here. And the cool thing is that when you repair this before birth and you stop the leak of that CSF, the cerebellum normalizes. The hindbrain herniation can reverse. And this doesn't happen when the baby gets surgery after birth. So that's very interesting and cool. Here's a fetus that had spina bifida. And then here's what I'm talking about on fetal MRI of a human with spina bifida. So here's the cerebellar hindbrain herniation. And this is about 1 month after fetal surgery. Look at that cerebellum. It's beautiful. So a randomized trial was conducted in 3 U.S. locations, UCSF, CHOP, and Vanderbilt. It took a long time to conduct this trial. It actually took 10 years. It took 3 years to get it off the ground, and then it took 10 years to conduct the trial. And it was finally published in 2011. And interestingly, 2011, I have a slide in my last talk that talks about this, but 2011 was the year that we started to see an increase in the number of fetal surgery programs throughout the world. And the findings of that trial are this. So 77 actually had fetal surgery. 78 were randomized to that arm and were analyzed in that arm, but 77 had fetal surgery. So that's only 77 cases. And then the trial was actually stopped prematurely because of the positive effects that they were clearly shown in the fetal surgery group. So fortunately, there was no deaths. In fact, there was very little maternal morbidity. And then the 2 primary clear benefits from the trial are, number 1, the need or the indication for a VP shunt in those that had fetal surgery was 40%, whereas those that had postnatal surgery was 82%. And then number 2 is walking independently. So in those that had fetal surgery at 3 years of age, 42% were walking independently, but those that did not have fetal surgery, it was only 21%. But there's a cost to the fetal surgery. There are some uterine effects. There's chorioamnionic separation. There can be oligohydramnios. The risk of placental abruption is a little bit higher. And then preterm labor, preterm rupture membranes and preterm labor is absolutely higher. And for that reason, the average birth in those got 1 weeks where there's 7 fetal surgery. Sometimes the birth is quite early. So that is a complication that we have to counsel about. And we consider fetal surgery for spina bifida a choice of the family. There's 2 options. You can have before birth surgery and you can have post-birth surgery. There are inclusion criteria and there are exclusion criteria, but those are evolving as more and more centers do this and we demonstrate safety. Another risk of fetal surgery is the uterus. So we are opening the uterus, we have to stitch it closed, and unfortunately the uterus and the amniotic membranes don't heal very well. And this is a great opportunity for future research, is how we can enhance the healing of the amnion and the uterine wall following surgery. But you can imagine it's a high-risk setting. We're cutting open the uterus, we stitch it closed, and we're asking it to heal, and yet we're keeping water inside the uterus, and we're keeping a baby inside we're demanding that it grows. So the baby's getting bigger, the uterus is going to expand while it's trying to heal. It's like asking a skin wound to heal, and you're constantly trying to stretch it apart. So it's a difficult healing environment. And in fact, in the mom's trial, about 35% of the time, the healing was not very good at the uterine wall. 2/3 of the time, it healed very well, and 1/3 of the time, it didn't heal very well. Now, some of this is technical and surgeon dependent, and some of it is just the situation. Here's some photos of fetal surgery for spina bifida, of us doing it here at the Cleveland Clinic. You can see that it was a huge team involved. Now, this is a 4.5 centimeter hysterotomy. So instead of seeing the whole baby's back, as I showed in that one photo, we're only seeing this little myelomeningocele defect. So this is the neural placode. This is a sac of the myelomeningocele sac. And then we're going to release that placode. We're going to allow it to fall back into the spinal canal. And then we're going to try to pull myofascia on top of that defect. We're not going to be able to make bone, but we're going to try to close it with muscle and fascia, and then we can close the skin on top of it. And this is that baby's pre-op MRI with the hindbrain herniation. This is the open neural tube defect right here. And then that cool thing, this is 4 weeks after fetal surgery. Look at the cerebellum, and then look at the back. It looks perfect. So that's a cool thing. So now let's talk about complicated monochorionic twins. The problem is in monochorionic twins, which are the minority, fortunately, of twinning, they share one placenta. In fact, you can have multiple twins, more than two, all sharing one placenta. So that's a difficult situation because they each get a different amount of placental mass, and there can be connecting blood vessels. In fact, commonly there is connecting blood vessels in that placenta, and that can lead to lots of complications. The most common is twin-twin transfusion, but you can have growth discordances, you can have discordant malformations. In fact, this can be monoamniotic, which makes the assessment even more complicated. But the bottom line is if you have monochorionic twins, the complication rate is higher. So fetal loss is much higher than if you have dichorionic twins. The preterm birth is much more common. Low birth weight, IUGR is much more common. And now twin-twin transfusion syndrome is a particular entity associated with monochorionic twinning. It affects about 10% or so of monochorionic twins. And it's kind of relatively common in terms of all twin pregnancies. And so you have to be able to pick it up, diagnose it in order to provide the best treatment. I won't talk about this so much, about the different types of anastomoses that happen, but the bottom line is the donor twin has oligohydramnios, will have growth lag, and the problem is a vasoconstrictive situation, whereas the recipient gets polyhydramnios, can get congestive heart failure, can get thromboses, and can develop hydrops. And this is a complicating problem that has a very high morbidity and mortality. There are 4 treatments that have been offered historically. There's amnioreduction, there's septostomy. You can do selective reduction in some instances, but the laser photocoagulation has the best results. In fact, our own Giancarlo Mari published on this in 2001 and talked about amnioreduction improving outcome compared to no treatment. But selective laser photocoagulation was developed in the 90s. Julian D'Elia was the first person to really advocate for this. In fact, Dr. Mari originally apparently was an opponent to that, but then the evidence started mounting until there was a prospective randomized trial that was published in 2004 that proved that laser photocoagulation was better than amnioreduction in optimizing the outcome of fetuses suffering twin-twin transfusion syndrome, stage 2 to 4. Here's a video that shows laser photocoagulation. You can see some vascular anastomoses there. Here we're mapping the placenta. And now we're going to go back to this anastomosis, and we're going to use the laser. The green light is just shows us where the coagulation is going to happen. You can see the laser fiber. This is all done through a single trocar that actually can be put into the uterus even with just local anesthesia. Commonly, we may use regional anesthesia as well. We try to avoid general anesthesia for these because we want the uterus to maintain uterine tone. You can see the little ultrasound image here. You can see the scope inside, and there's the placenta that's being coagulated. So I'll wrap it up there and say that fetal surgical repair of myelomeningocele and fetoscopic laser photocoagulation has been proven to be the best treatment for most fetuses with these anomalies, and it leads to the best long-term outcome. And that is the reason that there is more and more fetal treatment programs throughout the world. Thank you so much.